Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer that's been working with CCF for 10 years, over 10 years, in fact, to create video content, some like the live video series that you're going to watch today, some that are patient-centric documentaries, some that are really dense treatment-based videos, event coverage, hundreds, actually thousands probably, and I don't think that's hyperbolic, of videos that we have at your disposal for free, but all with the same mission in mind, and that is to spread awareness and educate people about neuroendocrine tumors. That is what we are here to do. So if you are new to the show or new to the NET journey, I want to say welcome. I'm glad you found us. This show is the value that we like to bring in this show is twofold. One, the information you're going to get from our guest presenter today, and two, the shared experiences and shared stories from the people within the community. This community is incredibly strong, incredibly supportive. So I urge you to lean on that. Reach out, introduce yourself in the comment section like you see everyone already saying. The regulars on the show are telling us good morning, telling us where they're from. Alaska, Canada, who else? Louisiana, Nepal in the house. We are broadcasting all over the world, and we have people tuning in all over the world. I promise you, you will not regret introducing yourself. These people are here to help you along. Now, before we start the show, we always want to thank our sponsors, Ipsen Biopharmaceuticals, because simply without their support, we wouldn't be able to do Lunch with the Experts. And we also have this disclaimer from them, and that is that the opinions expressed today by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest today, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, that's a lot of words, but all it really means is that last line. That's the takeaway. We're going to give you some good answers to your questions today, hopefully some good general advice, but we or our guests don't know your specific case. So take that advice, take those answers back to your home team, which does, and make the best plan and path forward for you. So today is our guest is Dr. Jaydira del Rivero, back to the show since about a year ago, which you just reminded me that last time we chatted, I was just had a baby, or not me, my wife, or was about to, and that baby, my son Bishop, is going to be 1 year old starting Monday, July 4th. He's a July 4th baby. So it's been a year ago. Dr. Del Rivero, welcome back to the show. Thank you for being here.
Thank you so much for having me here. I want to thank you, and of course, Ms. Grace Goldstein for the invitation, and the Carcinoid Cancer Foundation. I'm delighted to be here with you all today.
Absolutely. All praise to Grace Goldstein, the engine behind this foundation. We appreciate her so much. She is always the one in the comments adding the links. We'll talk about that a little bit later, but always a big shout out to her. So tell us a little bit about, for the folks that don't know you or weren't here last time a year ago, tell us a little bit about the work that you do, where you work, and the role that you fill in this NET community that we've talked about.
Yeah, of course. Thank you, Rain. I am a medical oncologist. I'm also in endocrinology. So initially, just to tell you a little bit of my background, initially, please. I did my endocrine fellowship many years ago, and I practiced as an endocrinologist for a little bit before I came back here at the NIH where I am, and I did a second fellowship in oncology. And as you may understand, by doing that, my main focus is in neuroendocrine tumors. I'm currently working at the National Cancer Institute as part of the NIH. And also one of the things that I'm doing here as part of being in a research institution, because the NIH is a research institution, is to be able to understand more about the biology of certain cancers as well. Part of the mission of the NIH is to be able to prolong the life of human beings and able to understand from the biology and pathophysiology of different diseases as well. As I say, as a medical oncologist here at the National Cancer Institute, I am the principal investigator of a natural history study for neuroendocrine cancers or neuroendocrine neoplasm. I'm also the PI of treatment studies here at the NIH for pheochromocytomas and paragangliomas, which is another type of neuroendocrine tumors. And also I'm collaborating with other investigators here within the clinical center and other treatment studies as well for neuroendocrine neoplasm. I hope that answered the question.
It definitely does, very thoroughly. I was just thinking about it. Sometimes, folks, we have people in here that are very specific in the realm that they work in with, like they're a lung net specialist. So really the topics that they will speak to are in that space alone. But today it sounds like we have a lot of options for great questions. I know there are a lot of para patients in the audience, so that's going to be a good opportunity for you all to get questions across, especially people interested in trials. So we, Dr. Del Rivero will be able to field a lot of the questions that we have today. And even though she doesn't work a lot with lung nets, she's even said that she's willing to take some of those questions. Most of her experience, she told me, is from studying those, right? And not necessarily working with lung net patients, but go ahead and start sending in your questions. But here, I want to go ahead and let you all know my job is to arm you with the tools so that I can do my job better, which is to, of course, serve you and get your questions answered. So we mentioned already that we don't know your specific case, and we can't really answer case-specific questions. It's too hard. If Dr. Del Rivero isn't your doctor specifically, it's too much in this format for us to understand all the nuances about your case, especially because in this disease, each case is unique and different, and therefore each plan and path forward is as well. So it's going to help all of us if you formulate your questions in a very generic way so that we can still give you answers and advice that help you get you further, down your journey or towards your goal. But if it's a really long thing with all the small details about your cases, that we probably won't be able to get to it. We get hundreds of questions. We try our best to get to everyone, and we don't. But the good news is we have the show every week, so we come back and answer your questions. But if you want to get it across, that's going to be the easiest way to do that. Now, if you have a question or see a question rather in the comment section that you also have, you can like that question or love it or any of the emotions that Facebook allows you to use, and that effectively upvotes it. So if I see 8 people have this question about PRRT or whatever, I'm really going to make sure that I get that question across because it's going to cover 8 people's questions in one answer right there. So we're getting as much work as we can do. So go ahead and start sending in your questions. We're going to try our best to get to all of them. And if you know someone that should be here, if you know someone who's typically here and you don't see them yet, if you know someone who would benefit from our guest specifically today, which, folks, it looks like you're already anticipating today's show because we've got almost 100 people in the room already, and that doesn't typically happen towards about middle way of the show. So it says a lot about our guest today. But if there's someone else that you've left out or we've left out, tag them in the comments, let them know the show is going on. And let's get as many people here as possible. So I see some questions coming in already. I wanted to ask one first, Dr. Del Rivero. One of the studies that you're working on now is this natural history study. And if I'm not mistaken, I want to learn a little bit more about that in general. But if I'm not mistaken, isn't it looking at environmental factors?
Yes.
Can you tell me a little bit more about that?
So of course, and I just wanted to kind of like give you a little bit of a background, if it is.
Yeah, please, absolutely.
Here at the NIH, as I say, I'm fortunate to be the PI for natural history study, specifically to study neuroendocrine neoplasm and adrenal tumors as well, pheochromocytomas, paragangliomas, as well as adrenocortical cancer. As initially, when I started my seeing patients with neuroendocrine tumors, I was part of the Rare Tumor Initiative here at the NCI, and I'm fortunate to keep working with them because our goal is to be able to see pediatrics as well as all adults with neuroendocrine tumors as well. And one of the things that we wanted to understand more about these tumors, if there is anything in the environment that may be associated with this. It's a prospective study, meaning a longitudinal study. When I say prospective, I mean that I'm able to follow patients over time. A longitudinal study as well, meaning for long periods of time. And
how long of a period of time in this case?
And as long as the patients are alive with neuroendocrine tumors. But we wanted to kind of like do certain analysis in terms for future publications either at 5 years or 10 years to help us understand more about the biology of these tumors. Now, the endpoint or the primary, what we call the endpoint, why we wanted to study these tumors is because we wanted to understand more about the molecular underpinnings of these neuroendocrine tumors. We wanted to understand more about whether there is any changes, as I say, in the environment that can make, there is an association, because the reality is that because I usually have this question from my patient is like, what caused a neuroendocrine tumors?
Right.
Tell my patients nothing that you did. That's why we call it sporadic, because we really don't know the cause of what is causing neuroendocrine tumors. That being said, this study would allow me to study patients over time, would allow me to understand more about what is the growth rate. As I say, if there is any molecular or genetic abnormalities associated with these neuroendocrine tumors. And once we have more information, we're able to then analyze what we found, and then for future publications, so that way the patients know what we're doing. One thing about whenever a patient comes to the NIH, and part of the study is that we like to do a comprehensive physical and physical exam, as well as family history, personal history, because we wanted to understand is there any commonalities among different type of neuroendocrine tumors. We also like to obtain tissue and in order to do molecular testing. As you know, Rain, and I'm sure you have heard from other NET experts here and Luncheon with the experts, is that surgery is considered in our patients with neuroendocrine tumors. Even in the advanced setting or metastatic setting, surgery is an option. And I'm very fortunate here that we have one of the best surgeons here for neuroendocrine tumors, Dr. Hernandez, Dr. Blakely. Our endocrine surgeons are phenomenal here. And sometimes surgery is an option here. So what we're doing is that we collect a piece of tissue, what we call fresh tissue, in order to study more about this, what is going on in the molecular level of neuroendocrine tumors, but also be able to do some what we call preclinical models. One thing about neuroendocrine tumors is that we don't have good preclinical models to do drug testing to understand if there is any signal on which therapies could be effective. And by doing this, taking a little bit of fresh tissue, trying to grow these cells, we will be able to do drug testing in the future, real time, as well as in the future. So that's one of the things that we're doing as well as part of this study. And also, as part of the Red Tumor Initiative as well, we wanted to understand what we call patient-related outcomes by having this diagnosis, how that affects you emotionally, pain, physically. So we wanted to understand every aspect of neuroendocrine tumors to go manage these patients at a more holistic level. I think it's important to also understand not only the biology of these neuroendocrine tumors, but also how a patient living with this disease affect in a day-to-day as well. So I don't know if that answered the question. I know it was a long answer.
No, absolutely. I appreciate it. We have questions coming in already, so I'm going to go ahead and take some of those. And we also have one about another study from NIH. So Joe says, last year, the NIH announced it was doing a study of patients' records. My info was submitted in July and August of 2021, and I didn't receive a response. Does this mean there will not be a response, or is it possible that a review of my case might still occur?
Very, very interesting. And I have to say, sometimes when a patient reach out, I have to say it may go to the spam. And I don't know if what's my spam email. I don't know if the patient reach out via email or phone, but I would just say I'm trying to be, most of my patients who know me, they know that I'm trying to be as very responsive as I can within 24 hours. So if this specific patient, Joe, and I'm sorry if you haven't heard from us, but I would recommend for you to email me directly or call me directly. I don't know if Ms. Goldstein can put my information on the link, and there is a phone number that you can call and an email as well. So just please reach out again. And I have to say, I'm so sorry that you haven't heard from us. My apologies about it. And I definitely want to help you. So please reach out again to me.
Yeah, thank you so much. And we have already put that link in there, Joe, for you to contact Dr. Del Rivero. But keep trying and be that squeaky wheel so that you can get the oil, so to speak. But thanks for your question. Let me know if you have anything else. Next from Diane, who has a PNET in the pancreas. And the question is kind of broad, but the question is what's good to eat? And so let's take that and if you will, or if you can, and talk a little bit about what might be good, what might not be good, and just some of the general rules in terms of nutrition or what to put in your body if you have a PNET.
Yes, well, thank you so much for that question. And it's a good question. And usually when I see my patients with neuroendocrine tumors, that's a question that often comes in the sense like, what do I need to do to make it better? And overall, there has not been any studies that specific diets. I know there has been some studies about the ketogenic diet and other type of diet, but in terms of the neuroendocrine tumors, there has not been any specific study that kind of help us understand if a specific diet could improve the outcomes of neuroendocrine tumors. That being said, I do recommend that every neuroendocrine tumor see a dietitian or a nutritionist. And the reason why is because, as we know, some of these neuroendocrine tumors, especially the small bowel neuroendocrine tumors, the flushing of some of the symptoms may be exacerbated for a certain food that or alcohol and so forth. But I will just say that every patient with neuroendocrine tumors, I do recommend seeing a nutritionist and dietitian. Another things about the somatostatin agonists that we use, either lanreotide or octreotide, sometimes that can cause diarrhea. And the reason why is because these drugs, is what we call somatostatin agonists, can inhibit some of the pancreas enzymes. And because of that, you may have some diarrhea. Some patients may lose weight because of that. We can help them by giving a medication called Creon, which is basically pancreatic enzymes. But I think it's important to always some of my patients to be seen by a dietitian or nutritionist. Now, what I usually recommend my patients is everything in moderation. I do recommend having a healthy habits, and what that means by healthy habits is trying to eat a diet which is higher on vegetables, and maybe decreasing red meats, and exercise. Exercise is always very important as well. Anywhere from 3 to 5 times a week, I think, to kind of like keep that healthy lifestyle. Another thing that I want to mention about neuroendocrine tumors, we call the neuroendocrine tumors being a chronic type of tumors, meaning that these patients live for long periods of time. And I think one important aspect about this is to be able to have the help needed in order for you to be well with yourself, whether exercise or support groups. I have to say that I'm a huge fan of Carcinoid Cancer Foundation and other organizations such as LACNIS and NCANS, because they provide so much information for patients. I understand that sometimes these neuroendocrine tumors is rare, and sometimes even between different genetic specialists, we have difference in opinions. But I think the more information you can get, knowledge is power. I always say to my patient, I think it's important.
Definitely.
The Cancer Foundation is a wonderful place to see so many net experts every week and to discuss and ask questions. And you have from oncologists to nuclear medicine to gastroenterologists. So it's an amazing place to acquire knowledge as well. But again, there's other organizations as LACNIS and others that I just mentioned. I think that it's important to gain as much information as we can, so that way you can be able to be well with yourself and to make the decisions that you feel more comfortable with. And I'm sorry, I think it was a long answer, but the short answer to the question is like, there is no specific diets that can really help. Just try to have healthy habits, leafy vegetables, less red meats, exercise. That's what I would recommend.
No, I like the thorough answers, because you answer multiple questions in there that people might have, and you're really giving people an education versus just saying like, Diane, eat leafy vegetables, good luck. So no, I appreciate that very much. No need to apologize. But Diane, to Dr. Del Rivero's point about education, this is what we're here to do at the foundation. I mentioned at the top of the program the hundreds or probably thousands of videos that we have. I urge you to lean on that resource as well. You can go to the videos tab here on the Facebook page, and also our YouTube channel. And we have this show, which has been going on 2 years now. In fact, 2 years next week. But we also have all the other videos that I've mentioned. On this show, we've had nutrition experts. We've done videos specifically on nutrition. Whatever topic that you are concerned with or interested in learning more about, I can almost guarantee you that we've done a video on it in the past 10 years that I've been working with CCF. So that's for you. Those are free. They're at your disposal. I definitely encourage you to reach out. And if you're having trouble finding what you're looking for, just message CCF and they can send you the video that's probably most appropriate for you. So use this library. I've been working for a long time to do this for you guys. All right, next question. Now, this is a LungNet question, but I think that you can field it because it's I'll just ask it. And a few other people have this. Nicole says, are the treatments for a metastasis to the lung, metastases lung nets, the same if you have a primary in the lung net as a lung net?
Okay.
Does that make sense?
Yes. I'll try to answer in different ways, and please feel free to, if I say something that you don't understand, please feel free to ask certain questions within my answer. So it seems that what the question is about treatments for localized lung neuroendocrine tumors versus metastatic lung neuroendocrine tumors. So, and in terms of, I have seen some of my patients, they have like a lung lesion that was seen incidentally in the CT scan, something that is biopsy and is consistent with neuroendocrine tumors of the lung. Now, just to describe a little bit, and I hope, Ray, you give me a couple of minutes to describe about the different types of lung neuroendocrine tumors. So in terms of lung neuroendocrine tumors, we have the typical lung neuroendocrine tumors. So that's based also on the Ki-67, has a lower Ki-67, usually less than 2%. And then we have the atypical lung neuroendocrine tumors, and those are higher Ki-67. Sometimes when the lung neuroendocrine tumors is localized, and I say sometimes we found incidentally because as a CT scan of the chest and there is a nodule with biopsy, that's consistent with neuroendocrine tumors. If it's localized, usually what I do is try to resect it. And we have an excellent thoracic surgeon here at the NIH, Dr. Huang, and also we have a lot of experience with these neuroendocrine tumors here because some of these neuroendocrine tumors may secrete a hormone this excess of hormone called cortisol, and that's kind of like cause what we call Cushing's syndromes. And we have Dr. Lynette Neiman here, who is an expert on that. And we have patients that had these lung neuroendocrine tumors that produces hormones. That's super rare, but we do have the surgical expertise here to resect those lung neuroendocrine tumors when it's localized. Sometimes some of the questions they ask me is that if there is a role for radiation therapy as well when it's localized. And I think if we can resect it, that's usually what I recommend to my patients because it's done and this will be no recurrence, hopefully, but and we can discuss about what will be the follow-up after that. But also, if there is any involvement of lymph node, for example, of the neuroendocrine tumors to medial to the vessels in the lungs, maybe surgery will not be an option. Maybe radiation could play a role there if surgery is not an option, but not once it's metastasized, meaning once it's went to other places, usually the liver, the bones. So that's when we need to discuss about systemic therapies. And one of the systemic therapies that we use for neuroendocrine tumors is called everolimus. The other systemic therapy that we use as well for neuroendocrine tumors is a combination chemotherapy, which is an oral chemotherapy called capecitabine in combination with temozolomide. So that will be another option in the systemic therapy as well. That being said, I had a patient, and again, something that I would like to mention here is the management of neuroendocrine tumors is personalized. It's not like one size fits all. It's personalized based on where the volume of tumors, or how much neuroendocrine tumors is in the body, whether they express the receptor, like called somatostatin receptor of the surface of the cell, whether they produces hormone of no, whether it's in two different parts of the body, but not in other places of the body. Sometimes we see neuroendocrine tumors that is in the lung and then the liver. So that being said, I had a patient with neuroendocrine tumors that has like one localized lesion and then a liver metastasis on one side of the liver. So in those situations, after discussing with our tumor board, the decision was like, well, we can do surgery, especially because she's young, very active, and then that way there is no evidence of tumor. But again, this is something that the management of neuroendocrine tumors, as I say, is personalized, has to be discussed with a multidisciplinary team and to discuss all possible options.
Got it. Thank you. You mentioned resection earlier. I have a question about resection. Caitlin says, what are the parameters for when resection is possible with stage 4 metastatic ACC?
Oh, yeah. So ACC, well, thank you so much for my ACC patients that tune in today. I appreciate it. And I say that, as I said earlier, one of the tumors that I study as well, besides the gastric and pancreas neuroendocrine tumors, is the adrenal tumors as well. And one of them is adrenocortical cancer. So ACC stands for adrenocortical cancer.
Got it.
Here at the NIH, and I have to say that Dr. Tito Fojo, who is an expert in adrenocortical cancer, he was here for many, many years. He basically selected as experts from surgery, from interventional radiologies, from pathologies, to kind of like also discuss adrenocortical carcinoma in a multidisciplinary team. In a subset of patients, it's not for everyone. Surgery may be an option for adrenocortical cancer. Sometimes it depends, right? So that's the reason why, similarly to the other gastric and pancreas or lung neuroendocrine tumors that we like to discuss our patients with a multidisciplinary team, similarly to adrenocortical cancer, we always discuss whether if the tumors, even if it's stage 4 in certain area of the body, whether we can resect surgically. That sometimes help because some of these adrenocortical cancer may produce hormones that can help to reduce the excess of hormones. But one thing that I always discuss to my patient, it has to be by someone who is an expert on doing surgeries in ACC. And here at the NIH, we have like 30 plus years of experience with surgeons that are familiar with adrenocortical cancer. And because of that, we do have a large referral of patients with ACC, and we usually discuss with our patients. But again, I think I am happy to also give an answer more individualized, because it's difficult to say which situations they are. It's not for everyone in a subset of patients. But again, we need to look, what the scans looks like, what is the Ki-67. And if anybody say what is the Ki-67 is what the proliferation index, how the cells are able to replicate under the microscope. We looked at under the microscope, and I think all of that needs to be taken in consideration in order to make the decisions about whether surgery or not could be an option for ACC.
Got it. Thank you. This is also from Caitlin. How does Lee-Framini syndrome impact treatment options? I'm not familiar with that syndrome.
Yes, thank you so much for that question, Caitlin. And Lee-Framini syndrome is what we call a cancer predisposition syndrome.
Okay.
Meaning that is associated with other tumor types. Breast cancer, leukemia is associated with Lee-Framini syndrome. Adrenocortical cancer is also associated with Lee-Framini syndrome as well. Okay. And usually the recommendations in a patient with if the question is I have ACC, but I also have Lee-Framini syndrome, again, the treatment will be personalized based on what I discussed with other neuroendocrine tumors, based on the volume of tumors, where they are, whether it's lung, liver, bone, other, because the adrenocortical cancer tends to go to the liver, to the lung, to the lymph nodes, sometimes to the bones as well. They rarely go to the brain, even though there has been some cases of ACC going to the brain, but that's rarely, and because of that, we don't necessarily do a CT scan of the brain in those situations. But I think in order to really give the proper management, first, we need to determine whether there is any other cancers associated with the Lee-Framini syndrome besides adrenocortical cancer. What I have seen is that when is adrenocortical cancer present, it's usually kind of like the dominant type of tumor, and we treat it like any other adrenocortical cancer. Sometimes, depending on what other tumors may have, and if we feel like we resected the tumor and there is no recurrence for a long time, even though ACC tends to recur. We don't necessarily recommend radiation in certain situations. Sometimes for adrenocortical cancer, depending on how the surgery went, they may recommend local radiation. But again, I think, as I said earlier, the treatment is quite personalized.
Got it. Thank you. Next question from Jean. Do you think taking hormones for other issues can cause NETs to increase in grade or metastasize?
Thank you for that question. And not to my knowledge, when we're talking about like estrogen in females or testosterone in male, there has not been any association to my knowledge that can increase or make the tumors bigger. So if that's the question, I hope this is a short answer. So
yeah, and for Jean or anyone else asking a question, if you have follow-up questions, please, chime back in if you're on the call, or if we misunderstand something and you need to clarify, you can always chime back in. Just give me a little bit of context because I'm reading so many different questions. I may not remember what you were referring to if you just blurt out like a word. So just always refer back to the previous question. Okay, Rose says, after 2.5 years on somatostatin, the script was changed to lanreotide. Due to the adverse side effects after 2 months of 120 milligrams monthly injections of lanreotide, I had severe hypertension. It's been 7 weeks since my last injection. So my question is, what effects physically does stopping the drug treatment suddenly have on my body?
Okay. I hope I understand the question, and please feel free to ask again if your question is not answered. But let me just repeat the question. So it seems that the question is, I was on sandostatin for some time, then it was changed to lanreotide. I developed some side effects due to lanreotide. And in this case, it seems that it's hypertension. And it's like, what do we do? Okay, so that's a good question. And I always, any patient that I see with neuroendocrine tumors, definitely I like to understand from symptoms, and I really like to explore what's going on with my patients as well to make sure that we gave the best guidance possible. So let's go back a little bit about what somatostatin agonists are. So we have two of them. One is sandostatin, the other one is lanreotide. And what it is that it binds to the receptors in the surface of the neuroendocrine tumors. It's called somatostatin receptors. And when it goes there, then it releases some events in order to have two functions. That's what these injections has. One function is to help the symptoms related to hormone excess, whether it's from the pancreas neuroendocrine tumors. Some pancreas neuroendocrine tumors produces hormones, whether it's from the small bowel neuroendocrine tumors. So that's one of the function of these injections that helps with the symptoms related to hormone excess, but at the same time, it helps to slow down the growth of the tumor. It doesn't necessarily shrink because some of the questions that I have from my patients is that, well, I've been on this treatment for a year, but I don't see any changes. And not changes, as long as everything is stable, is good, because that's one of the functions of these injections, to stabilize the growth of the tumor. Now, some patients, I have seen that some patients may take this sandostatin, may have some side effects. So the most common side effects is usually bloating, diarrhea, sometimes it can form gallstone as well. So that's one of the reasons why whenever a patient had surgery for neuroendocrine tumor, sometimes the gallbladder is taken out, thinking in the future that they may need these injections because it can form gallstone. Rarely can affect the thyroid as well. But high blood pressure is not something that I have seen and commonly. And what I have seen sometimes is like if a patient has a side effects related to sandostatin, sometimes I change it to lanreotide, and it seems that patients may tolerate it better or vice versa. In terms of efficacy, because as the other questions I always get, which one is better? We feel like it's the same, either sandostatin or lanreotide. The efficacy is the same for the two of them. Lanreotide is easier to administer because it's more under the skin compared to sandostatin, which is more intramuscular, and the needle is bigger than the lanreotide. But hypertension is not something that I have seen related to these somatostatin agonists. That being said, I think it's important that you discuss this either with your physician, your primary care physician, your oncologist, because if your blood pressure is high, there's medications that help us lower the blood pressure as well.
Got it. Thank you.
And this is thinking, I'm so sorry to make my comment. This is thinking about, if we're thinking about the gastric and pancreas neuroendocrine tumors. No, we're talking about pheochromocytomas and paragangliomas. That's a different thing, right? Because pheochromocytomas and paragangliomas are tumors can be in the adrenal gland or outside of the adrenal gland. They produce adrenaline, which is kind of like the fight and flight response that we have.
Yeah.
And sometimes that can cause blood pressure, but this is a different story, different treatment modalities, but I just want to make sure, that I address different aspects based on your question.
Totally.
And I hope your question is answered. Thank you for that.
Thank you so much. I love having you on the show. From Josh, hi, Dr. Rivero. First and foremost, thank you so much for your time. A couple of questions. So I'm going to go to the second one first. When a typical or atypical NET primary is found early, stage 1 of the 2, would you usually recommend minimally invasive surgery with a watch and wait approach, or would you prefer curative resection, even if it's radical?
Okay. That's a good question. And that's a question that I actually discussed with my thoracic surgeon here, Dr. Horn, who is fantastic. Let me see if I can answer the question in different ways. So the question is that I have a lung neuroendocrine, because when you say typical or typicalism, we're talking about the lung neuroendocrine. And based on your question, it seems that whether minimal invasive procedure can be done or more aggressive surgery, but that will also depend on the location of the lung neuroendocrine tumors, whether the lymph nodes are also affected as well, because I can definitely guide what will be the surgical approach. And again, I'm not a surgeon, but sometimes when I discuss it with either my thoracic surgeon or my other pancreas surgeon, the approach will depend on what is the extension of the tumors. For example, if the lung neuroendocrine tumors is localized only one area, I think usually they do it minimally invasive. If they have lymph nodes, I remember I had a patient that had a lung neuroendocrine, but also has many lymph nodes. That was a more aggressive approach. If the goal is to get you without evidence of disease, that's what we say NED, so no evidence of disease. That's the goal of no evidence of disease, and that's a possibility. The extension of the surgery will be what is, whether it's localized, whether there is lymph node involvement. So those are the things that we usually discuss with our surgeons.
Got it. Thank you. And another question from Josh. What is the best way for patients to get in touch with you or the NIH NETS team for information on trials, case second opinions, et cetera?
Oh, great. Thank you for that question. And I think Grace, I don't see the links.
Yeah. Yeah, she did put that information, but let's do this instead. Like, what about information on trials?
Okay, great. Thank you so much. So in terms of, when I say trials, we have a natural history study, and then we have treatment studies. And that's something that, if I have a couple of minutes, I would like to discuss as well.
Yeah,
the treatment studies that we have at the NIH, we have, and we're extending in terms of treatment study for neuroendocrine tumors. One study that I would like to talk to you about is a study for metastatic pheochromocytomas and paragangliomas with Lutathera. As we know, Lutathera was approved for the management of gastric and pancreas neuroendocrine tumors. And in order to get to this treatment, they need to have positive receptors in the surface of the cell. Similarly to pheochromocytomas and paragangliomas, approximately 95% of these patients may express a somatostatin receptor. So it makes sense, to do this, to give Lutathera, especially they express the receptor. So we have a study here. Dr. Frank Lind is the principal investigator of the study. I see those patients with him as well as a medical oncologist. He's a nuclear medicine and oncologist as well. And he has a study of this Lutathera for patients with advanced metastatic pheochromocytomas and paragangliomas. We also have another study, and I'm excited about this study, is a Lutathera in combination with a pill called olaparib. And just to give you a little bit of a background about that, we know that Lutathera works. We know that Lutathera can definitely, stabilize the tumors as well. But could we make Lutathera more effective? And that's one of the studies that even Dr. Chauhan is doing as well. And just to give you a little bit of a background, I don't want to get too much to the technicalities of this, but a little bit of the background is that radiation caused as Lutathera, because of type of radiation, it breaks the DNA of the cells. And what your body is trying to do is trying to repair that. So if we give something that inhibits that repair, it can potentiate the effect of Lutathera. It can make it more stronger. So that's the rationale or the hypothesis of doing the studies. A lot of the combination treatments with Lutathera are still on clinical trials. And the drugs that inhibit that DNA repair, so it's called DNA repair inhibitors. One of them is olaparib, the other one is peposertib, the other one is triapine. So Dr. Chauhan has two of those studies of Lutathera in combination with peposertib or triapine. So I know that he just finished his phase 1 data study for triapine. So now he knows what is the effective dose, and now he's going to move to the phase 2 study. Here at the NIH, we have Lutathera in combination with olaparib. So that's opened, but we're hoping to enroll patients within the next month. I think this is a good study. We're trying to understand more about how this treatment works, because as I say, Lutathera we know it's effective, but if we give something to kind of like make Lutathera, work better or shrink the tumors more, I think that's something where the science is going. So I'm excited about that. The other studies on the horizon that we are going to open here very soon is a study called Vesultifan. So Vesultifan is an oral medication. It was approved recently for VHLs, for Hipilando-related tumors, mainly the kidney cancer, or the pancreas neuroendocrine tumors related to VHL, von Hippel-Lando, as well as the hemangioblastomas or central nervous system hemangioblastoma. And the reason why is because it's inhibit a protein, hypoxia protein within the tumors. And pheochromocytomas and paragangliomas, we feel that based on how these tumors are, that this medication could be effective. So that's what the question that we want to answer. At the same time, pancreas neuroendocrine tumors may express in the tumor, is not in every cell of the body. And let me just explain a little bit germline versus somatic. So germline is everywhere in the body. So and you can pass to your kids. That's what VHL is. And that's why we have this cancer predisposition syndrome, which is a mutation, which is germline. But also we have mutations within the tumors, and that's somatic mutation. That doesn't do anything that you can pass to other family members. It's just within the tumor. And we're learning as well with pancreas neuroendocrine tumors that they express these different mutations, and approximately 35-40% may have this VHL, and by using this drug, we hope they could be affected as well. So there is different mechanism why we wanted to do the studies, but we're excited about that, and it's going to be open very soon. And we also have a study of lanreotide for pheochromocytomas and paragangliomas to see if it really slowed down the growth of the tumors like we see with the pancreas and GI neuroendocrine tumors. I'm sorry, I think that was a long question, but I think it's important that, we have these different studies, and excited that, we're still opening more studies here in the clinical center.
Well, speaking of Dr. Aman Chauhan, he is actually in the audience today, and he says, hola from Lexington.
My good friend, Dr. Chauhan, and I'm so happy you're here. He's my good friend. He's brilliant. He's a brilliant, and I just, he's a good example for me, a good motivation for me, I have to say.
Yeah, love him. Yeah. From Effie, curious if there's any data on the incidence of having both neuroendocrine cancer and a pheochromocytoma or paraganglioma.
Mm-hmm. So the question is, let me just repeat the question if I got it right. So the question is if a patient with neuroendocrine carcinoma can also have a pheochromocytoma?
Yes, but specifically, she says, is there any data on the incidence of having both? So yes, can they? And then is there any information about how often that happens, et cetera?
No. Not necessarily. So there is no any data of any correlation of having pheochromocytomas or neuroendocrine tumors at the same time. That being said, there are some cancer predisposition syndromes like MEN1, multiple endocrine neoplasia, that may have a pancreas, is associated with pancreas neuroendocrine tumors. Sometimes very rarely may see an adrenal tumor that could be an adrenocortical cancer. We're talking about earlier about ACC. We have seen a patient that has a pheochromocytoma, but that's rare, and there's really no association with that. We have other, there is a condition called MEN4, and it's a different a different, so we have MEN1 and we have MEN4. There is different mutations associated with how these tumors present. MEN1, menin or MEN1 gene is the cause. Now for MEN4, there is a different gene, is CDKNB1. And sometimes they have also the tumors associated with MEN4 is pituitary tumors, or tumors of pituitary gland, also parathyroid tumors. Usually those are benign, meaning that they don't cause any issues. And parathyroid adenomas, or there is when the parathyroid glands becomes bigger, they may activate or may cause your calcium to go out from the bone to the circulation, and that your calcium levels is higher or high. And also in the MEN4, they may have a pancreas as well, neuroendocrine tumors, and it has been documented that a pheochromocytoma has been seen with them. But again, that's super rare, and that's very specific of MEN4. Now, if coincidentally you have a neuroendocrine tumors and a pheo after, and it's, once we see that, usually that kind of like trigger for us to do genetic testing and refer our patients to a genetic counselor just to do a proper panel for germline testing. But without that, it is very difficult to say that there is any association. I don't know if that answered your question.
Got it. Thank you. I think so. But let us know if it didn't, or if you have any follow-up questions. From Donna, is there any way to study, or are there any studies being done regarding the occurrence of NETs in patients who have had previous cancer diagnoses? This is a question that comes up a lot. Any possible relationship? I was diagnosed twice with breast cancer 30 years ago, and then small bowel NETs 15 years ago. I've been told there's no relationship. Any information or any studies going on about that?
That's an excellent question. Thank you for that question. And I have to say, I need to refer to Dr. Julie Hallett. I know that Dr. Julie Hallett has been here, and that's one of the things that she discussed. So she did a study in terms of patients with neuroendocrine tumors, if they have any other associated cancers as well. And what she found is that certain type of neuroendocrine tumors, either pancreas or small bowel neuroendocrine tumors, may have an increased incidence of other cancer types, and like colon cancer or other rectal carcinoma, GI cancer. I don't remember Dr. Hallett mentioning about breast cancer, but the question is like, what do we do with that information? Do we need to screen for each cancer? So it's kind of like an ongoing study from Dr. Hallett that she wanted to understand more about that and to really give the proper guidelines. So just to summarize, there has been a paper from Dr. Hallett that said that certain neuroendocrine tumors may be associated with higher risk of other cancers, but something that we're still ongoing and studying. And but the management will be similarly to what we have done with other neuroendocrine tumors as well. That doesn't change how we treat neuroendocrine tumors.
Got it. Thank you. From Rosemary, can you review our case with scans and reports and give us your opinion without being seen in person?
Yes, we can. Yes, we have an excellent team here. We have our tumor board who meets every week. And yes, we can definitely, review scans. We can definitely, it's a process. So let me tell you how it works. So whenever a patient reach out to me, I refer my patient, include my referral office, who they're fantastic in trying to obtain records and scans from outside. Then once we have all that information, we then discuss with our big tumor board if needed. Sometimes I review it and then I look at the scans. Sometimes I may not need the opinion of the whole tumor board. I kind of have a little bit more of a mini tumor board with maybe just the surgeon and the pathologist, or the surgeon and the intervention radiologist. Usually our tumor board, we have the surgeons, the endocrine surgeons, the Dr. Hernandez, who is our pancreas surgeon. We have endocrinologists, radiologists, intervention radiologists, and also whenever there is a specific question that we have that require other specialties, we invite other experts within the clinical center as well to give their opinion. But yes, we can definitely, review scans and have a virtual appointment. So one thing about that we learned from COVID, I know it was terrible during COVID time, but we learned to kind of like do these virtual appointments, virtual visits.
Absolutely.
Yes, that's something that we're able to do.
What we learned how to do in COVID have a weekly show where we have on guests from all over the world to take questions about neuroendocrine tumors. So we had done a couple of Facebook Lives, but when COVID hit and I wasn't traveling and making films anymore for the time being, we started this show. And so some good things have come out of it.
Yeah.
This is one of them, and the ability for telehealth is as well. From AG says, if a biopsy has not been done on a patient who has a tumor on her pituitary, but has liver metastasis as well, how is grade determined? And also he mentions a parathyroid has been removed and MEN1 confirmed in her, including her young children.
Okay. So we are asking so let me just rephrase a little bit of the question. So we're talking about a patient that have MEN1 and the clinical presentation or the current clinical presentation of his MEN1 diagnosis is pituitary tumors and is parathyroid adenoma. So in MEN1, usually we see parathyroid adenoma very often. So let me just explain a little bit what is that. So parathyroid glands are very in each size of your thyroid gland. So it's kind of like the thyroid gland is like a butterfly shape. And on each side of that, we have these little tiny parathyroid glands, and they're responsible to regulate your calcium in the body. If these kind of like become larger, we call that an adenoma, then they have the capacity to kind of like stimulate calcium production, and usually comes from the bones into the circulation. Usually those are benign. The pituitary adenoma or pituitary tumors are usually benign. Sometimes they may produce a hormone called prolactin or growth hormones that's rarely seen, but usually those are benign. Now, if you're telling me that you have some liver lesions, I would definitely like to biopsy, because I wonder if that may be from a neuroendocrine tumors in other part of the body, like the type make neuroendocrine tumors, not neuroendocrine tumors. MEN1 can have not only pancreas neuroendocrine tumors, but we have seen neuroendocrine tumors in other part of the body, the lungs, the thymus, the ovaries. So I think that would be important to explore more what these liver lesions are. We need to biopsy and then do the proper evaluation based on the MEN1 guidelines.
Got it. Thank you. Folks, we have just shy of 10 minutes left and many questions. We're going to try to continue to get a few more before we wrap up today. Sue says, and many other people have this question as well, can low grade turn into high grade?
That's a very good question, Susan, and thank you for that. It can. It can't become higher grade over time. It doesn't happen commonly. I mean, it's nothing that we see it in all neuroendocrine tumors, but it can happen, and we have seen it. So how do we know that? And that's kind of like one of the things that we try to also explain to our patients, is that what we discussed earlier is that neuroendocrine tumors, we call it more like a chronic type of cancer, because we know that our patients live for many years, and sometimes in the scans they may be stable as well for many years. And sometimes from one scan to the other every year, I may not see changes and they may be stable. But if I see a change in the biology of the tumors, meaning from scan to scan, I see more of a growth, more of a rapid growth compared to the prior scan, that tells me like, well, maybe the biology is changing. And in those situations, what I usually recommend is repeating a biopsy just to understand if the Ki67 also changed as well. I would like to mention that Dr. Diana Reedy and Dr. Nitya Raj from Memorial Sloan Kettering did a study, beautiful study, where they biopsy neuroendocrine tumors over time, and they see that there is a change as well in terms of the Ki67, in terms of what the mutations are associated with the neuroendocrine tumors. So, but yes, it can. So the answer to the question, it can, but usually that kind of gives me an idea, a hint, when do I think that is the biology is changing, when I see more of a rapid growth from one scan to the other. And in those situations, I like to biopsy just to see if it changed, if the Ki67 is higher, because based on the Ki67, it can also guide me what would be the treatment algorithm for my patient.
Got it. Thank you. From Dorothy, I love this question. I understand that an endocrinologist should be part of my cancer team, but why? What can they do for me that my oncologist can't?
Okay, thank you, and great question. And as I said earlier, maybe I'm biased because I'm an endocrinologist, but I like my endocrinologists to be involved for many reasons. Number one, because we know that these tumors can be functional. For example, the pancreas can secrete different hormones, insulin, and that translates in low blood glucose. It can also secrete other hormones like somatostatin, like glucagon. So those hormones that they secrete, usually the endocrinologist can give us a very good understanding and how we can treat it. Like if there is a neuroendocrine tumor that produces insulin, the endocrinologist certainly will know what treatments we can recommend that can also help the management with the oncologies. Similarly to the GI neuroendocrine tumors that is producing these hormones called serotonin, and we know that for that we use sandostatin, and in those situations, sandostatin can affect the thyroid. So if I feel that my patient is feeling tired, gaining weight, and maybe I'll need to check the thyroid, and that's when your endocrinologist may also, be an important person in your management as well. Pheochromocytomas and paragangliomas, that's another tumor, neuroendocrine tumors that your endocrinologist needs to be involved. And the reason why is because of the symptoms associated with the excess hormones causing high blood pressure, and they know for sure what medications they need to use in order to block the excess of hormones, so that way your oncologist can then decide what systemic therapy we can use for our patients.
Got it. From Jason, our mom was recently diagnosed with ACC. Sorry to hear that, Jason. We've had a lot of ACC questions today, by the way, so that's something for us to think about. Her medical team is doing the best they can, but they have limited experience. That's a common situation. How do we respectfully share our findings and information like what you're sharing today while respecting their role as her primary medical team? Such a great question, and I know a lot of people have this question.
Thank you for that question, and definitely I'm going to answer that question. Adrenocortical cancer is a rare cancer, and in order to really understand what treatment options we recommend to our patients, we need to see a specialist. Similarly to neuroendocrine tumors, we need to see a NET expert. The same with adrenocortical cancer, we need to see someone who knows about the disease. Being rare, we need to know, we need to kind of like refer to a physician who may tell me what we need to do. Maybe a general oncologist may not know all the different options of clinical trials like we do, and that's the reason why it's important that your medical oncologist work with someone who has an expertise in neuroendocrine tumors. And we do, in adrenocortical cancer, and we do similarly to neuroendocrine tumors, right? So they go and see an expert, and they go with their primary or local oncologist, and they communicate. So they communicate and all the time what will be the next treatments that we could recommend. Similarly to ACC, I see patients from all over the world, and I like to work with the oncologists to understand where is the disease status, what treatments we recommend, whether surgery is an option, whether ablation, embolization, what we call liver-directed therapy is an option. So I think all of things needs to be considered, but I feel like in order to really improve the outcomes in ACC, they need to be seen by someone who has an expertise in adrenocortical cancer. And your doctor should understand that. And if the doctor doesn't understand that or doesn't want to collaborate with someone who knows about ACC, maybe you need to find another oncologist who is willing to work with an expert. I'm sorry to say that, but I think it's important that we work as a team. And another thing that I recommend to my patients is like having second, third, fourth opinion. It's okay. I advise my patients to do that. And the reason why is because even for other neuroendocrine tumors, maybe a difference of opinions, but at the same time, I want my patients to feel comfortable with the decision that they make as well. And that's the reason why you usually advise to seek for many opinions on that, especially with this rare cancer.
Got it. Question from Josh. I've read that somatostatin analogs can be beneficial for reducing tumor growth and anti-angiogenesis, even for those without receptors. What are your thoughts on this?
Yes, usually the standard practice is that we recommend these somatostatin agonists like lanreotide or sandostatin for those patients that have the 68 gallium dotatate or 64 copper dotatate scan. So because we know that they have the receptors by seeing on the scan. So in those situations, it makes sense to recommend somatostatin agonists, like lanreotide and somatostatin. If a patient doesn't have the receptor, we don't necessarily recommend. But that being said, medicine is not an absolute science, right? If your doctor recommends and then you see that there is an effect, I mean, you can continue, but that's usually not the standard.
Got it. Thank you. Comment from Tina says, thank you for providing this forum for us newbies to learn and gain understanding of this unusual cancer. Tina, that's exactly what we're here to do. So I appreciate you saying that, and I'm glad that you are finding value from it. So I appreciate you being here at the show, and that goes for everybody. And this is our job. So I'm glad that it seems to be working. Dr. Del Rivero, thank you for being back here. I think everybody has really, really enjoyed the information you've shared with us today, and I appreciate you being here with us again.
Yeah, and can I make one last comment?
Absolutely, you can.
Thank you so much for having me here. And I have to say to my patients, please reach out. Please ask as many questions as you can. As I say, knowledge is power. We're here for you. We're supporting you on your journey. We have net experts like Dr. Chauhan that we really want the best for all of you. And I really want you to don't hesitate to reach out and ask any questions. Sometimes when you go and see a physician, you sometimes don't remember all of the questions. It happened to me, it happened to everyone, but please write your questions, ask anytime, reach out. We're here for you. I sometimes feel our patients are our best teachers. We're a team together. So we're here for you, and we want to make sure that we get the best possible treatments for you and the best recommendations. So we're here for you. Thank you. And thank you so much for Carcinoid Cancer Foundation for all that you're doing. I think this is really so helpful for our patients. And I hope that was helpful today as well.
Absolutely. And thanks to you folks at home again for joining us today. And as always, we hope this program helped answer some of your questions. And please reach out to ccf@carcinoid.org or here on the Facebook page if you have any further questions. Thanks, as always, of course, to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next week on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.
Thank you so much.